Good morning. Everybody awake? All right. I'm Ron Terwilliger, and it's my pleasure to welcome you here to Denver, the Mile High City. It's been a favorite place of mine in the world for a lot of years, and we're proud and pleased to have our annual housing symposium here. This year, focusing on healthy housing and healthy places. I founded this housing center at ULI 7 years ago, but I've been a member for 40 years and have been a houser. My career was with Trammell Crow Residential. I retired 5 years ago, but I couldn't stay away, so I'm back building apartments in the Southeast. But most of my philanthropy is in housing now. I continue to chair the Global Development Council at Habitat for Humanity, where I've served on the board for 13 years, and I chair Enterprise Community Partners, because my belief is that housing is a fundamental human need. You know, food, clothing, and shelter, right? We're talking about shelter. Today we're going to talk about shelter that is healthy for human beings. According to our Habitat research, there are 1.6 billion people in this world that are in poverty housing. And I'm going to chair the federal government policy concurrent session here recently. We'll talk a little bit about research we've done on the condition in the United States. But as you all may know, 20 million of our households spend more than half their income on housing. So you have different definitions of what healthy housing is, but certainly an affordable home would qualify. I want to thank ULI District Council Denver and our sponsors, our speakers. We should have about 200 people here for this conference. I want to thank Lynn Ross once again for the outstanding job she always does in organizing these conferences. You know, housing is a basic human need, and unfortunately, it's really hard to get philanthropists interested in housing. I've been frustrated over my many years at working at Habitat trying to get people to give to housing. They give to health and education. They're the number 1 and 2. And they're not unimportant, but as I view it, it's a three-legged stool with housing as the big leg, and with a decent, affordable house located in the right place, health and education outcomes will follow. So it's an affordable home, and interestingly, you all may know this, we're really housing hogs in this country. We have an average square footage of about 2,500 square feet on our single-family homes, and Habitat builds houses outside the country probably an average of 600 square feet, which makes our homes here very expensive and makes it hard for so many families to afford them. I think about secure tenure is one of the issues that we deal with at Habitat, and it was a term I'm not familiar with. It's one we probably take for granted in the United States. But if you think about families in a home where they're insecure about how long they can stay in that home, outside the U.S., it's a lot of times that the legal system doesn't even give them deeds. Or in some countries, believe it or not, women here, ladies, you can't inherit. Women can't inherit houses in some countries. Habitat works hard on changing those rules. Here in the U.S., if you don't have enough money to pay your mortgage or your rent, then you don't have secure tenure. And so it's an important concept. And when I think about the theme of this, healthy housing, healthy places, healthy house consists of a physical aspect of it. You know, is the roof leaking? Believe it or not, there are a lot of houses around the world that don't even have a concrete floor. They're earthen floors. You talk about not having health in those kind of houses. The materials inside the house are important. And where the house is positioned in the community is equally important. At Enterprise Community Partners, we think about housing as a place for opportunity, but if you can't get to transit, you can't get to health, you can't get to shopping, you're in an unsafe neighborhood, then the house is not placed where you want it to be. So it's a multidimensional problem or challenge. In the U.S., you know, I think we don't do nearly enough for the people in need. but I'll leave my soapbox to another time. Today and tomorrow, you'll hear from a lot of experts connecting health and housing in virtually all of the dimensions. And I think it's terrific that Lynn has organized around this theme. It'll be really enjoyable. I know that the panels will be great. We have concurrent sessions running, I think, as you all know, after this initial introductory session, and hopefully everybody has their guidebook. So with that, welcome again. I'm going to bring up Kathleen Carey. She's the Chief Content Officer and Executive Vice President of the Urban Land Institute. She's been here since 2012. Prior to that time, she was with GE for a long time, 15 years, and she's a Six Sigma gal from GE. She's responsible for the strategic direction and development of Urban Land Institute's content. So please welcome Kathleen Carey.
Thanks very much, Ron. And I'd like to add my welcome to all of you, especially to our partners and our sponsors. I would love to list you all, but then they would definitely get me off here with a hook because they've only given me a couple of minutes. So at the risk of failing to mention somebody, I just extend my thanks to all of you who are here today. And welcome to Housing Opportunity 2014. As Ron said, I'm Chief Content Officer for ULI, and I work in Washington, D.C. In my role, I'm responsible for ULI's research centers and initiatives, as well as education and advisory services. So in my job, I get to see the breadth and the depth of everything that's going on with ULI members around the country and, in fact, around the world, and our partners as well. As you may know, let's see if I can get the slides to go. As you may know, ULI has over 32,000 members, and many of you here are longtime ULI members. And some of you are not ULI members, or maybe not yet. But I have to say that the best part of my job is actually the members. Because at the end of the day, it's not about the research or the white papers or even the conferences. It's about the power of what the members do with what they learn at ULI and how they share and apply their learnings to drive action and change in their communities. So this morning, I was asked to say a few words about content at ULI and the scope of our content, which is quite expansive. And while I work in Washington, D.C. during the week, I actually live in a small town in Connecticut. I was walking through our town last weekend, and I was thinking about our new mayor, or as we call him, our first selectman, who we elected last fall. And I was thinking about all the things that were on his plate. And I thought, you know, I will bet you that about 80% or maybe even more of the challenges that our new mayor is facing are around land use and the built environment. All the subjects where ULI members are frequent voices at the table, whether it's housing or resilience or sustainability or infrastructure or building healthy places or public leadership, and on and on and on. And as I walked around my little town in Connecticut, I thought about housing. There's a new senior housing project planned. And I thought to myself, you know, that's really ULI. ULI is way engaged in housing, as are our friends and partners, all aspects of housing. There's a new library expansion planned in town to respond to changing technologies and demographics and the town's desire to attract and retain its residents. That sounds like ULI to me. Track improvements in the commuter rail line seem never-ending, and ULI members are interested in infrastructure and transportation, as Ron mentioned in his remarks, making sure that housing has access to good transportation. Plans are now being drawn up in my town to reconfigure the town park and the beach to make it more pedestrian-friendly and more walkable. And through our Building Healthy Places initiative, ULI is engaged in this space too. And by the way, this is not my town. I just like this picture. A historic home in town is actually being physically picked up and relocated to make room for mixed-use development downtown, topics in which ULI members have a keen interest. That's not my town either, but I couldn't find a better picture of my town, so there you go. Finally, parts of the river in town will have to be dredged to help prevent the flooding that's occurred twice in the last several years. shutting down many downtown businesses for months. And many homes near the river and the Sound are still being rebuilt. And making communities more resilient to face whatever comes their way is something that ULI is very engaged in as well. And just as these issues are front and center in my town, they're front and center at ULI and in towns and cities all over the country in one way or another. And ULI members are engaged in driving change in both policy and practice everywhere they live, work, and play. So I know that you're here for the next day or so to talk about housing and health in particular. Housing is a key component, if not the driving force, behind all of the topics of interest to ULI members, whether it's resilience, sustainability, health, infrastructure, or leadership. Earlier this week, I had the opportunity to be in Portland, Maine, and I worked with a ULI Advisory Services panel there, where ULI members are advising the city of Portland and South Portland, its neighbor, on how can those two cities be more resilient in the face of sea level rise and climate change. And at one point, I had the occasion to spend a few minutes with the mayor of Portland, and he said to me, "We're really happy to have ULI in town, and we are very grateful that you're here. And I know you're here to study the issue of resilience and sea level rise and extreme storm damage, but I really hope that the panel has a few minutes to spend on the issue of housing in Portland." And it struck me as I was speaking with the mayor that here is somebody who is really connecting the dots. He told me that Maine has the oldest housing stock in America, and he's very concerned about that. And as he spoke, I thought, yeah, he really is getting it. He understands that unless his community can provide quality, affordable, and available housing to the citizenry, they will neither be healthy nor resilient. So it's all connected, with housing as a strong foundational element. So one final note this morning from me, and that's on leadership. It is very exciting to have all of you here, because you are the thought leaders. In an age of technological advancement, so many of our interactions are taking place online, whether it's email or Skype or texting. There is still nothing that replaces getting a few hundred really smart people in the room and letting them share their ideas. I know you have a lot to share and are willing and able to share it here and beyond to drive change. It's very powerful. I look forward to the impact to come from Housing Opportunity 2014. I thank you, and now I'd like to say a few words of introduction for our keynote speaker this morning, Dr. Megan Sandell. Dr. Sandell is a nationally recognized expert on housing and child health. She's an associate professor of pediatrics at the Boston University Schools of Medicine and Public Health. She's the medical director of National Center for Medical Legal Partnership and a co-principal investigator with Children's Health Watch. In 1998, Dr. Sandell published with other doctors at Boston Medical Center the Doc for Kids report, which was the first of its kind, focusing on how housing affected child health. Following that, she was author on a second report documenting how asthma, lead, injuries, homelessness, food insecurity, chronic disease, and educational attainment were all affected by housing. Dr. Sandell has written numerous peer-reviewed scientific articles and papers on the subject of the connection between housing and child health. She has served on numerous committees and advisory boards, such as the National Center for Healthy Housing and CDC Advisory Committee for Childhood Lead Poisoning Prevention. She lives in Brookline, Massachusetts, and is the mom of 3 children. Please join me in welcoming Dr. Megan Sandell.
Thanks. So good morning. How is everyone? Good. Oh, let's see. Ooh. Thank you. So I'm really thrilled to be here today. This is something that I'm passionate about, and something that I've certainly dedicated my life to, is making this connection between housing and health a really easy connection for people to understand. And so one of the ways that I have tried to make that clear is I often will talk about a stable, decent, affordable home is like a vaccine. And so today I'm going to walk through a couple of different ways to make that connection. I want to talk a little bit about an overview of how housing matters for health. I could spend hours and hours going through the research, so I'm not by any means going to give you a comprehensive look, but I'm going to focus on these kind of 3 pillars. This idea of what do we know about stability of housing? What do we know about quality of housing? What do we know about affordability of housing and how those things are connected to health? I then want to kind of walk through a little bit of why housing could be a vaccine. What are the ways in which we understand vaccines? We understand them to have multiple benefits, to provide you kind of immunity against different things, to talk a little bit about how housing can have a long-lasting impacts and how that can be a really important way to understand it, but that we understand that they are differential, right? They're not the same for everyone, and we accept that, and so I want to talk a little bit about that. And then I want to talk about how we view vaccines, how they benefit both individuals, but then also how they impact society as a whole, and how housing can kind of fit into that analogy. And then lastly, I want to talk a little bit about healthcare. I sit in the healthcare world, right? I work at a hospital, Boston Medical Center, and I want to talk about how housing and healthcare can be better bridged to deliver the housing vaccine. So some of you may not be familiar with what Children's Health Watch is, and we are a research policy network that is based in Boston, and we really are dedicated to improving the health and development of young children. And we really focus on how to alleviate economic hardships, and particularly how the public policies can be tools to do that. We focus on 3 key economic hardships. So we focus on hunger, which sometimes is called food insecurity. We focus on unstable housing, which sometimes gets called housing insecurity. And then we focus on actually keeping the lights or the heat on, which for low-income families can be really difficult, and that is energy insecurity. And those 3, if we think about those as kind of an interchangeable kind of pyramid of circle or triangle, those things are all interrelated for particularly the patients that I see. And I want to talk a little bit about how we understand that interplay. And then we really focus as pediatricians and researchers, how can we bring evidence from the front lines, from our research, to policymakers and to advocates to try and develop policies that actually improve the health and development of young children and their families. So we collect data in 5 cities, in emergency departments and in primary care clinics. We are focused in collecting data in Boston, in Baltimore, in Minneapolis, in Little Rock, Arkansas, and in Philadelphia. And we focus exclusively on caretakers and kids with young children, 0 to 4 years of age. And the reason we focus on that is because they are generally an invisible group. They're not in school yet, and yet we know this is when you're going to grow the brain that you need for the rest of your life. When we think about a knowledge-based economy, if you don't grow your brain in that 0 to 3, 0 to 4 window, people talk about it now as the first 1,000 days, because they're talking about prenatal through to the first 3 years. That's really critically important. I don't want to imply that your brain stops growing or your brain stops working after age 3, but this is really a critical time period and why we focus on Children's Health Watch at this age group. So one of the things that we published in the American Journal of Public Health is this idea of how does housing insecurity impact the health of very young children? And so when we think about this, this is something that's incredibly predictive of health. And this is where I think everyone understands the connection between homelessness and health. But there is a continuum between homelessness and stably housed, and that can be unstably or insecure housed. So that can be things like being overcrowded, right? You having more people per bedroom space, and that's been shown to be moderately housing insecure and impact your health. And then there's also this idea of you're moving frequently. So we define it as moving 2 or more times in a year as being severely housing insecure. And what we know from that is that this is incredibly predictive of bad health outcomes. And when we think about dose response in medicine, right, moderately housing insecure may give you, say, a 30 or 40 or 50% increase in, say, poor child health, but that multiple moves 2 or more times in a year can be a 2-fold risk. So the evidence on housing quality and children's health has really exploded, particularly in the last 15 to 20 years. And we definitely understand it really well now, particularly around developing or worsening of asthma. So we understand things like pests and cockroaches, mice, or other things are related. So for instance, if you are living in a home that has cockroaches and you're allergic to cockroaches, you're 3 times more likely to end up in the hospital with an asthma attack. And having to stay overnight in the hospital with that asthma attack. And we understand that now molds or chronic dampness can be incredibly important both in the development and in the exacerbation of asthma. I think that obviously tobacco smoke is something that may be more residential, but we're understanding new ways in which housing and housing policies can play out, particularly around smoke-free housing, that may be both beneficial to the individual and society. I can't talk about housing quality without talking about lead. I think we've recognized the connection of lead to healthy housing for over 100 years, and yet our understanding of the depth of which lead exposure can be difficult. The Centers of Disease Control recently lowered its action level to 5 micrograms per deciliter. This is a much lower level. It means that 500,000 children in the United States are potentially getting exposed, and this is a huge area of disparities. And I think that, full disclosure, I sat on the committee that actually lowered this action level, and it was really important to understand what the evidence was telling us and to really emphasize that we need to prevent the exposure before it occurs. And then the other thing that when we talk about housing quality that people may not always understand is this heat or eat phenomenon that many patients or people will make, where they have paying huge amounts for their energy bills, and that has impacts on their health and well-being. But what's interesting is we make the connection between housing quality and physical health, but there's new research that actually makes the connection between housing quality and mental health. So this is a brief from the MacArthur Foundation on How Housing Matters, which is a wonderful source of information about the most up-to-date research about how housing matters, and they take the very scientific articles that we researchers publish and they actually put them into layman's terms, and so I really encourage you. But this was put together by Professor Rebecca Levine Coley at Boston College and her colleagues, which talked about how poor housing quality actually impacts children's emotional and behavioral problems. It impacts how they do in school. And so that when we think about these multiple benefits of housing, it's not just physical health. I want us to think about mental health, think about education, think about economics. Affordability is something that I think was talked about. 20 million people are spending more than 50% of their take-home income on rent. And so we published at Children's Health Watch a brief called Behind Closed Doors, which looked at this concept of just a simple question of, were you behind on your rent or mortgage in the last 12 months, and predicting whether or not that had health implications. And we saw huge amounts of child food insecurity. So child food insecurity means not just that your household is food insecure, that you don't have the readily available of food regularly, but that you as a child are having your meals cut down, right? So it's a really extreme. Parents cut down their meals first, but for children to be food insecure is really, really dangerous. That children and mothers were more likely to be in fair or poor health, that children were more likely to have developmental risks, less likely to be ready for kindergarten, then mothers were more likely to be depressed. So something as simple as being behind on rent can be hugely predictive of health. And so what we sometimes will talk about is the interrelationship. We talk about that the prescription to end hunger may be affordable housing. You all are building affordable housing and you don't realize that you may be ending hunger in your communities, because in many ways when we think about it, when you compare children on subsidized waiting lists, so they're eligible for affordable housing, they're not able, that's 3 out of 4 families, right? They are much more likely, the families that are in subsidized housing, to be food secure. They're more likely to be a healthy weight. They're less likely to be underweight. They're more likely to be a well child, not be an underweight, not be overweight, not be hospitalized, be of normal development. Those are really important things. And so one of the things that we've been doing, because we're in 5 areas, is we are able to do site-specific briefs. So we've actually published in the last couple of years, with support from the MacArthur Foundation, site-specific looking at this idea of, are you housing insecure? Are you overcrowded? Are you behind on rent? And other things. And so when we look at this, for instance, in Philadelphia, over half of the families that we're interviewing are housing insecure. We see that only 42% are stably housed, about 1% are homeless, about 5% are moving frequently, 26% are behind on rent, and 25% are overcrowded. And so when we talk about housing as the vaccine, there's a huge need for this vaccine out there, and yet we don't have enough of it. So why would housing act like a vaccine? And so I think that I can get a little geeky. I'm a pediatrician, I'm a doctor, I want to kind of talk about all these things, but I think in as simple layman's terms, I think that vaccines are things that provide multiple benefits. They're things that provide you immunity for other things than necessarily just what the vaccine is against. That it's acknowledged to have these differential effects, and that it can be targeted or tailored for specific groups, or provide different schedules for different groups depending on risk. Why do we think vaccines are good investments? Why do we spend billions of dollars actually on vaccines every year? Is because we understand them to have benefits not just for individuals but for society. So I want to talk a little bit about how housing can act as a vaccine. So this is another research that we published now close to 10 years ago in 2005, where we looked at, again, these families that were on the waiting list for subsidized housing, so they were eligible for it, versus families that were in subsidized housing, so they had that protection against the affordability. And what we found was there was a twofold protection. If they were food insecure, so they weren't having enough food on a regular basis, the risk of stunted growth was twofold protected in the group that had subsidized housing, right? So you're 2 times less likely to be stunted growth. So if you're not growing appropriately, that means you're not growing your brain. And so think about that multiple benefit against hunger affecting your growth was from subsidized housing. I think that you can't talk about housing without talking about one of the biggest studies that has looked at this, which is called the Moving to Opportunity Study. This is called a randomized controlled trial, which in the medical world is kind of the gold standard of how do we suss out what are real differences that can be attributed to interventions. This was a study that was done in 5 cities, Boston, Baltimore, Chicago, Los Angeles, and New York. And what they did is they were really trying to look at how relocation was going to affect employment, income, education, and health and well-being. And they took almost 5,000 families in those areas and they randomized them. So think of kind of the flip of a coin to assign them to 3 groups. One got a voucher to move, but they could only move to a neighborhood that had less concentrated poverty. And they had significant counseling to help them get to use that voucher. The other group that was assigned was a traditional voucher. You got to move, but you could move wherever you wanted to. And a lot of those families actually continued to stay in relatively concentrated poverty neighborhoods. And then about a third of the group was assigned to stay in their public housing development, which was typically in concentrated poverty. And then they've continued to study this group in 2 waves of study, 4 to 7 years and 10 to 15 years later. So some of you may have heard of this study that was published in the New England Journal. Jens Ludwig is the first author, which looked at how did this Moving to Opportunity study impact obesity, severe morbid obesity in the women of these families. And what they basically looked at was severe obesity, which is defined as a body mass index above 35, morbid obesity above 40. And then they also looked at this blood test called hemoglobin A1C. This is an indication of diabetes risk, that you're starting to be potentially developing diabetes. And what they found was there was a 3 to 4 percentage point difference between the low poverty voucher group and the control group. So that if your BMI was 31% versus 35%, your BMI was 14 to 17%, and your hemoglobin A1C being elevated was 60% in the low poverty group and 20% in the control group. Now these may not seem like relatively big differences, but what I'll tell you is that if this was a diabetes medication, it would be funded on every pharmacy of every healthcare institutions in the United States. A 15 to 20% effect overall is the bar to which we set for putting things on formularies. And so that something that was absolutely not designed to have that intervention has that amount of impact is amazing. But I have to obviously talk about both sides of the coin here. And so there was another study that was published in JAMA recently, which looked at the health and well-being of the boys and girls 10 to 15 years later. And what they looked at is they looked at the prevalence of mental disorders in the adolescents. And this is where you'll see differential effects. So the boys in the low poverty voucher group had higher rates of mental disorders than the control group. They diagnosed them by a validated questionnaire. So this was not doctor-diagnosed mental disorders, but a fairly high bar. And they saw differences of 7% major depression versus 3%, post-traumatic stress disorder 6 to almost 2%, conduct disorder 6 to 2%. But it's interesting, the girls in the traditional voucher group had lower rates of mental disorders. Now, the authors were really interesting in how they talked about it around whether the communities that accepted these families, whether they differentially accepted the boys versus the girls. But I think it is important to weigh the evidence and always think about it all in totality. So when we think about vaccines, I think that it's accepted that I, as a healthcare provider, need to get a flu shot every year. Now, why do you think that is important? Partly it's important because it's important I don't get the flu so I can continue to show up to work. But it actually is more that I don't give the flu to other people, right? This is a study out of the British Medical Journal, which showed that the effects of mortality and morbidity and healthcare utilization for having home care workers actually get flu shots. So not just that the actual people in the nursing home got the flu shots, but that the caretakers they got, and they saw differential rates and they saw differential effects. And when we think about why do we now routinely vaccinate against chickenpox? So many of you in the audience may be old enough that you got chickenpox as a kid, whereas my children haven't gotten chickenpox. They got vaccinated against chickenpox. Why do we do that? Well, the health benefits related to vaccination against chickenpox are actually relatively low. So you actually don't get a great return on investment for every dollar that you put in terms of healthcare savings. You get a $5 benefit related to lost work. So we vaccinate kids against chickenpox, not necessarily to prevent them from getting chickenpox, but to make sure their parents can continue to work. So we think about that societal benefit changes the cost-benefit ratio. I often think that when we think about how housing impacts health, we only think about it in one way. How does housing impact health? How does it impact energy? How does it impact economics? How does it impact the neighborhood? And we don't think of it collectively enough in terms of how we come up with that return on investment. I think that what's interesting is there's more and more research about this interplay of individual and societal benefits. This is a recent research from the Framingham Heart Study. So this was a study that was from Framingham, Massachusetts, which is a town in the suburbs outside Boston. And it was started in the 1950s to actually look at heart disease. And they now are 3 generations in where they have followed these families. And what they looked at was the foreclosure rate around people living in Framingham, where there was a significant amount of foreclosure. And they looked at the difference between whether the foreclosed properties were owned by a bank, which typically meant that they lay vacant, versus whether or not they were bought by a third party and typically put back into use. So many of you are in the housing world where you would buy those foreclosed properties and put them back into use, right? And what we actually showed was that people who lived within 100 meters of a significantly increased percentage of foreclosed properties had more weight gain over that time period from 1987 to 2008. And that actually resulted, this is coming out in Circulation this month, that it actually had increased rates in your blood pressure, right? So think about that. Like, think about, if I had had another 20 minutes, we would have started talking more about how your zip code actually may mean more to your health than your genetic code, right? But think about how you all, as the people who are delivering the housing vaccine, you're actually having these impacts on societal levels of people that you may not even be touching. So I think if I've convinced you that housing is a vaccine, then what's the business case to start talking about having healthcare think about investing in it? And this is a great book that I'm really, it's kind of was a eureka moment reading it. I get no disclosure, full disclosure, I don't get any kickbacks for this book. It's the investing, when we think about America's healthcare paradox, it's by Betsy Bradley and Lauren Taylor. And it's this idea where we in the United States spend an enormous amount on healthcare. We spend more than everybody else. This is from 2009, so it's actually even a little out of date. We now spend over $8,000 per person on healthcare. We outstrip everyone, right? So these are the 34 industrialized countries. And yet, when we think about what we get for that kind of bang for your buck, we're pretty bad, right? Out of the 34 industrialized countries, we're 25th in maternal mortality, we're 26th in life expectancy, 28th in low birth weight, and 31st in infant mortality, right? So we don't get very good spending. But this is what's interesting, is when we think about what we're spending on healthcare, but when you start adding in what we spend on other social spending that we know have impacts on health, like housing, our ratio of social to health spending is the worst in the world, right? So when we think about what that means, we look at the total amount of healthcare spending is in the blue bar, right? So there we are. And then we look at the red bar is the social spending. And so in most of the industrialized world, for every dollar you spend on healthcare, you spend $2 on social spending. In the United States, for every dollar we spend on healthcare, we spend 55 cents. So what's interesting, and I've actually talked with the authors about this study, it's really an interesting interaction, is part of this is the culture of the United States, is that we hold up healthcare, we lionize healthcare as this important thing to invest in and to put money to. And we don't lionize social spending to achieve health benefits. It's very much about the other, right? They actually looked at some of these studies of different culture of health in other places, and we really don't have as much of a culture of health. We have a culture of health care, and in some ways that's why I end up talking about housing as a vaccine, is because it's easier to talk about it in healthcare analogies, right? People kind of get them. But I think that what's important to think about is how are we going to bend the cost curve and improve our outcomes? Is it that we need to change this ratio, right, where we need to spend less on healthcare and shift healthcare dollars to be more into the red arrow? Or do we actually bring under the healthcare umbrella some of the things that we know that you all are doing, the social service work that you're putting on your line items? That could be it. And I think this is a real debate, is it that we need to actually change the bar so we're higher, so there's more investment on the social side, or do we need to actually bring healthcare more to the table? When we think about what that looks like, I think that the good news is that there are places that are starting to think about this and are starting to think about, can you actually invest from the healthcare side into the housing side? So this is a slide from Marketplace that was covering that United Healthcare put $40 million into an affordable housing trust fund in Minnesota. And I think what's important to keep in mind is it wasn't the healthcare foundation that did it. It was the healthcare side. They used healthcare revenues to do that. $40 million, right? And they viewed it as that it was in their best interest to increase the stability of housing for their people that were in their healthcare pool. You hear this term a lot, population health. And population health is really about how do I make populations healthier as a way to necessarily make their constituents healthier. The other really interesting article was from the New England Journal, was talking about housing as healthcare, right? And it talks about how New York State is using Medicaid dollars to try and think about being able to spend on the Medicaid side. How could they look at that as a better way to spend? And this is where, again, you talk about differential impacts, differential benefits. So for them, the role of the social determinants of health and the business case for addressing them is immediately clear when it comes to homelessness, right? Because you know that 1.5 million people are experiencing homelessness, and you know that they use an enormous amount of healthcare dollars. And so that when we think about this in the table, there's a lot of really interesting examples of this, where you could use Medicaid dollars to actually develop affordable housing. You could use healthcare dollars to actually help pay rent for people. You could use healthcare dollars to actually renovate housing that is being used. I was actually yesterday in Chicago at actually a hunger summit that ProMedica healthcare system was putting on, because they're committed to ending hunger in their patients. ProMedica is a healthcare system from Northwest Ohio and Southern Michigan. And yet what they have come to the realization is that to end hunger, they have to also think about housing. And they're literally taking some land that they own and are actually working with local housing developers to actually build senior housing. And they're going to open a clinic there. And they view that as a win-win for them, because they're going to be able to take care of elders, be able to keep them in their homes longer, and be able to do that. Their cathedral from Vermont is another example of where you can make this tie and you can do it. I will admit that as a pediatrician, I worry sometimes if we set up only to invest in housing in the most vulnerable in terms of the people who are costing the system the most right now, we potentially lose out on the fact that investing in children is an incredible return on investment, but you have to wait 20 years to see the return. And so when we think about that, I want to continue to talk about young children and families and pregnant women as also really important to the debate. And so when we talk about these things, I think that often, I hope I've convinced you that housing influences health. I think it's no longer the conversation of does housing matter, it's how much does it matter. And when we think about that, we have new understandings of these interplays, right? Of thinking about stability is beyond just ending homelessness, but it's stably housed. You're not moving, you're not overcrowded, you're not behind on rent chronically, you're not having to choose between rent and eating and your heat bill, right? That those things are incredibly important. That we understand that housing quality is important. 6 million people live in substandard housing in this country, and we even bumped that number for a long time. And we need to think more creatively about it because we understand it now to not only impact physical health, but mental health. And I think that when we think about affordability, those hardships are all interrelated. And so it may be as much about building beautiful, affordable housing that's energy efficient and green. And I was really excited to see some great green panels because I think that that may be as important as anything else. I hope I've convinced you to think about housing as a vaccine. It is a cute phrase, but it is one of these things where you're trying to get at this idea that it provides multiple long-lasting benefits, that it's not just about one benefit, it's about building your immunity against future difficulties, and that we understand it to be differential, but we know that about vaccines now. We don't stop vaccinating people. We just think about different ways to booster or to provide extra services. And then I think really how we pay for it is going to be about bridging health to healthcare. And we're going to be thinking about bridging housing to healthcare. And how can we build those bridges with the evidence base to do that? And so I'm really excited to take some questions and talk more about that. Thank you.
Dr. Stamdale?
Yeah.
My name is Kurt Krieger. I'm from the Pacific Northwest. In your research with respect to your Children's Health Watch, are you starting to see any correlation between autism in children? I realize the 0 to 4 is a pretty young cohort to start to diagnose autism, and any connection or interconnectivity between housing quality and autism, or as you say, food insecurity and autism, or some of the other indicators? Yeah,
that's a great question. So we have recently started to get really interested in this concept of children with special healthcare needs, of which autism is a really large one. We're also interested, obviously, in asthma, and then also interested in congenital defects. We have some research that actually suggests that if you're homeless during the prenatal period, if we compare you against someone who was, say, homeless in the postnatal period, that we see huge differences in terms of low birth weight and prematurity. So the reason that I say that postnatally homeless is the idea that the same factors that would drive you to become homeless should be the same in both groups. The timing, though, effect becomes then critically important. And so that when we're thinking about how this affects child development, I think you're absolutely right. We are understanding more and more the interrelationship between how this housing instability, whether it be homelessness or housing insecurity, impacts birth outcomes and then impacts the development. Autism being one of the child developments, but other developmental delays. We've been really interested in working with chambers of commerce, that they are really interested now in affordable housing because it's their future workforce, right? And so that when we think about what that looks like, you can't show up to kindergarten not ready to learn, and there's really good evidence that housing instability predicts that. And then I think the other key thing to think about is that we're looking at the interaction of work and stable housing. And what's pretty clear is if you have a child with special health care needs, you're much less likely to be able to enter the workforce, and therefore it becomes this vicious cycle. You have a child to take care of, you can't earn enough money to take care of them, and then you end up with worse health as a result. And we're really interested in trying to understand how much of the Medicaid costs that we're paying in this country are attributable to preventable hospitalizations and ER usage because of these hardships, and can we bend the cost curve and look at the investments in that way?
Thank you, Dr. Sandell. Very interesting and provocative presentation. I was a little confused by some of your data around subsidized housing, because it seemed like you were saying two different things. On the one hand, you showed data that families and young children living in subsidized housing
Yeah.
are significantly healthier
Yep.
than those not living in subsidized housing. But then you had other data that got more into neighborhoods,
Yeah.
and that even if families are living in subsidized housing in highly concentrated poverty neighborhoods, their health is not as good as low concentration. And maybe it's just more nuance going on, but what is the message that you're trying to convey about the importance of subsidized housing and where it's located?
Yeah, no, thank you. I appreciate that. I think in many ways, subsidized is really about affordability, right? Are you able to only have to spend 30% of your take-home income on your rent? And we actually look at it both from, are you able to move with that subsidy, or whether or not you are in a fixed subsidy, whether it be public housing or whether it be more of a tax credit or other situation. And I think that when we think about that, it is acknowledging that we are understanding neighborhood effects much more deeply than we have previously. And so that what will happen is that there may be differential effects that fight against each other. So for instance, you may be protected against having to spend too much income on your rent, and you'll see health benefits related to that because you're going to have more money for food or other things. But that the flip side is that you may have, if you're living in a concentrated poverty neighborhood, you may have more violence, and that stress is going to differentially affect your health. And so that it may be that you'll still see a net gain with the subsidized housing. That's what we see in our research, is that subsidies, regardless of where they are going to be good for kids. But we have to acknowledge that part of this, and I am excited to hear Jason Roberts later this afternoon talk about, how do we make communities healthier as a whole, right? How do we think about improving zip codes? There's really amazing new research out there. The county health rankings from Robert Wood Johnson Foundation are really amazing, where you can actually look county by county at places. And then Dolores Acevedo Garcia at Brandeis has both two websites, one called diversitydata.org, and then a new one that she recently launched called diversitydatakids.org, which can get down to the census tract level a lot of these different opportunity indexes as they relate. This is an opportunity index developed by Kirwan Institute at Ohio State, and thinking about how do we understand the interplay of where your kids go to school and where there are effects related to walkability, where there are effects related to healthy food environment and things like that. Because I would say clearly affordable housing is a net good for people, and that's to me the take home. That's why I call it the vaccine. But we have to think about whether or not we're muting the effects of the vaccine with where we place that housing. And that is where we need to think more holistically about how do we put good housing together. There's a great session this afternoon around health impact assessments and thinking about how to use those as tools to do better community development with where housing is sited.
Hey, Megan, good job. So I was interested in the moving to opportunity. Whenever I see it, it always triggers a lot of questions for me. I saw it presented several years ago when we were in France for a conference, and the French were like, wait, let me understand this. You picked people up and you told them to move and you expected them to do better? That they felt this was just like so American, that we completely ignored the social connections aspect and the cohesiveness of communities, and that we were in fact breaking that up by virtue of this grand experiment. And it's kind of troubled me ever since, and I still wonder. I was writing an introduction for someone the other day, and it was talking about Hope 6, and Bruce Katz calls it the best regeneration effort in the last 40 years. And I just wonder, is there consensus on this? Do people really believe that? In my mind, I think, well, of course, if you take a Cabrini Green and you look at it today, people have to be better off from a health standpoint. But at the same time, we've done some studies in that area, and some of the residents report, it's a minority view, that they miss the old Cabrini Green. And I just wonder, kind of in future research, how do we tease out some of these issues that have to do with social cohesiveness and kind of our grand experiments around concentrated poverty?
Yeah. No, thank you, Rebecca. I think that in a lot of ways, I think our understanding of social network research is really I think in its, I won't say infancy, maybe it's in its toddlerhood or it's in young childhood, it's thinking about social networks both as positives and negatives. So there's actually research that if your friends are overweight, you're more likely to be overweight, right? And if your friends are doing well in school, you're more likely to do well in school. And our understanding of what that means can be really interesting. And there's more and more talk about how do you think about building social network and social cohesion as, say, part of housing. So there's really interesting experiments in San Francisco where they're looking at community gardens, right? And they're saying, okay, we generally accept that a community garden may be a good thing, but we may not appreciate the full extent of why a community garden would be good, right? We may necessarily think about, are there ways in which a community garden not only gets you healthy food, but gets elders out of their apartments, gets them to have the coping strategies or the social cohesion that you can necessarily do. There's really good research out of something called the Project for Human Development in Chicago neighborhoods that's looked at this long term about how social networks can be really positive. And so I tend to take the evidence as glass is half full. I think there's overwhelming evidence that the moving to opportunity was positive. But what I tend to say is that we can't ignore these negative pieces. I think we have to understand that racism still exists in our society, and that in many ways, when they deregulated those vouchers, a lot of those families moved back to those neighborhoods. And why did they move back to those neighborhoods? Well, a lot of them, through qualitative research, talked about the fact that when their food ran out at the end of the month, the corner store gave them credit, and they could go in until their SNAP benefit came back in, and they missed that, or the ideas of segregated neighborhoods being generally thought to be really bad, and yet I think that we have to be really thoughtful about how you desegregate neighborhoods to not have unintended consequences. And I think that for the most part, I totally agree with you. Moving to opportunity was great in the fact that randomization takes everything off the table in terms of what are the things, is the marker of what happens versus the mechanism. That randomization helps you with that tremendously, but it still is teasing out what it means. And I think that I'm somewhat agnostic about mobility. I think mobility is good, but I think only mobility is good with the services, with the counseling, with the social supports and other things. And I still think that we have to be realistic that we need to make the places people live healthier and not necessarily just have a strategy of moving everyone.
Morning, Doctor. Very great presentation. I really enjoyed it. I'm Chris Smith with the Colorado Health Foundation, and we have been thinking a lot about housing and particularly active design and how that's integrated into housing. And one of the pillars that you mentioned in your presentation was quality.
Yeah.
And so I was curious how the medical community, from your perspective, defines quality in housing and how that definition is either changing or sort of staying the same.
Yeah, no, that's a great question. So I do think that the definition of housing quality has been changing. So it started, I think, mostly as an absence of definition. So it was absence of pests, right? Absence of excessive chemicals, absence of, say, mold or chronic dampness. And I do think that more and more it's about how can housing make the healthy choice the easy choice, right? So when we think about kind of, I've had people talk about, can you design a house that has a reading corner, right? Put in a bookshelf, right? Because you're trying to encourage reading, you're trying to encourage things as a way to do that, or that you're trying to come up with a more universal design across the lifespan so that it's as good for a family that has a 5-year-old is it for someone who's 65 years old, right? And how do we think about ways in which to do that? I do think that there are some pretty clear now design choices, right? So trying to do smooth wipeable floors that are easier to clean than carpet, which has a much shorter half-life. Being able to use products that have less chemical content, being able to think through green renovations in a way to be able to reap the energy savings and therefore put potentially higher end things or being able to do more things with that. And I think that I will say that we also have started getting really interested in moving upstream. So what I often talk about is that I got interested in housing as an intern at Boston City Hospital, and I admitted a child with asthma. And really sick. We're in the ICU. There's nothing scarier than seeing a kid struggle with every breath, right? You're seeing the ribs suck in. You're thinking you may need to intubate this child to get them to breathe. And you sit there and you say, okay, what's different? This kid didn't have bad asthma before, and they're in the ICU, and they're so sick. And I was sitting down with the family, and I asked what was different, and they talked about the cat that they had gotten. And I was really puzzled. I had looked at her chart. She was allergic to cats. So I asked the family, well, why did you get the cat? What was the answer? Mice. They had found a mouse in her bed. So you asked yourself, right, that family made a horrible choice, and it was so difficult for them, and that probably choice was the thing that ended up putting her in the ICU. And it was this eureka moment for me where I was like, I can't send this kid home, right? Like, the prescription I wanted to write was not more medicine, right? Because no amount of medicine I was going to write was going to make that kid healthy. It was really about writing the healthy home prescription. And so more and more we're thinking about moving upstream. This is a phrase that a friend of mine, Dr. Rishi Manchanda, talked about, the upstream doctors, and this idea of not just reacting to everything. So not just waiting until the patient comes and sees me with the asthma attack and I ask about the housing problems, but now let's start doing what we did in Boston. Let's do a proactive rental inspection ordinance. Let's make sure every single unit meets quality standards. Now, you all in the affordable housing world are used to that, right? Like, you're used to getting kind of your grades every year in terms of the quality, but a lot of housing doesn't get that inspections, and that's a public health intervention. So for us in the health world, we don't want to react anymore. We want to proactively help people be healthy, and that can be about trying to improve housing quality, not just about the absence of, but actually how it can actually promote health.
Hi, I'm Marisa Novara from Metropolitan Planning Council in Chicago, and thank you so much for your thoughtful presentation. I'm wondering if you might have some information that would help. We've been working a bit on how we could convince our city to provide more incentives for affordable units to be built in profitable markets, and one of the things, clearly there will be a downside from the incentive side from the city coffers. And so one of the things I've been trying to think about is we clearly get a lot of bad press for the crime in Chicago. What's interesting, though, if you look deeply into that, is that our crime has actually gone down quite a bit. It's that our crime inequality has gone up tremendously over the past 20 years. And so clearly that has a major toll on people in the neighborhoods in which it's now 15 times. You know, the difference between, the study I read was the difference between a low crime area and a high crime area used to be like 1 to 3, now it's 1 to 15. And so I wonder if there's anything you can arm me with around, how housing can be used as a tool toward violence reduction when it's dispersed differently than we might be doing it now.
Yeah, so it's interesting. So Robert Sampson has written a bunch around particularly how residential instability and crime are connected. He wrote the most recent book is called The Great American City, and he actually talks a lot about Chicago. And and that's a lot of work from this Project for Human Development in Chicago Neighborhoods, which is a publicly available data set for the data wonks in the group. It's housed out of actually the University of Michigan. And it's really interesting. I do think this concept of stable housing to build healthy networks is something that's really interesting to think about, right? Like how do you get people, when they see things that are suspicious, interact with, say, their police or other things? And there's really good evidence that if you don't know who your neighbors are, if you don't feel comfortable asking them for $20 when you need it, if you don't feel comfortable letting them watch your kids, that you're not going to necessarily, when you see an act of crime, actually report it. And so when we think about kind of violence as like the social toxin that like enters your body, this is what Dr. Roz Wright, who's at Mount Sinai now, talks about it, is we understand that, then it really is something that we need to talk about and we need to think. The other thing that I will lay out is healthcare institutions have particularly, like out of the 5,000 healthcare institutions, big hospitals, 3,000 of them are not for profit. And the 3,000 that are not for profit, in order to get that IRS designation, they have to show that they're doing community benefit. And typically the IRS has not particularly set a high bar around that community benefit, and they've also are now required to do these community health needs assessments. And so one thing is that if City Hall may not listen to you as the messenger, it's time to find a new messenger for your message. And is there ways in which you can work with healthcare institutions to talk about the community benefit that is going on by investing in these housing, and particularly healthcare systems that own health plans, Medicaid managed care plans, are really into this idea of, can I impact my members by improving their health? And they're much more likely to think about housing as a tool in that. That's the Medicaid experiments in New York. And are there ways in which you can do it? I talk a lot to housing audiences. I love talking to housing audiences because you guys get the health connections. It's sometimes harder for me at the pediatric and medical side to get medical audiences to think about housing. But it is this idea of, if you all that are developing affordable housing, ask your tenants where they get their health care. Like, it's pretty easy. You recertify them every year. Ask them where they get their health care. Just that single question will help you figure out who your natural partners are in this work and who you would necessarily work with. And then I tell healthcare people, geocode your data. You know where they live. Figure out who those housing partners, how many people are in public housing, how many people are with Community Development Corporation housing, and then that will tell you where your things. It's really silly for a healthcare institution to pay a case manager to sit in an office at a healthcare site and call, right? Like, you'll never find them. But if you can imagine paying part of your case manager's salaries by the healthcare side, that makes a lot more sense. It's a win-win situation. And so I think that's one way to do it. And then arming the research, I would try Robert Sampson.
Hey, Megan. So I'm thinking a little bit about hotspotting, and the healthcare industry's attempt and others to really look at sort of the frequent flyers, high healthcare utilizers, because we're looking at sort of data about what we can do. And I kind of want to flip it the other way, which is to kind of hit them where there's pain. And the pain is they're going to be penalized for high healthcare utilizers. But when you look at the hotspotting data, one thing that comes up a bunch is mental health costs in Camden and some of that, and around those housing developments. So I'm just wondering about strategies housers might use to engage with healthcare payers and providers around making a case for reducing high healthcare utilizers. And while I thought asthma would be productive, it's kind of in tier 2 for the high healthcare utilizers. So can you talk a little bit about that, particularly if we were thinking about like low-income tax credit deals and other things, and where we would push certain developments? Is there a way to make that nexus and therefore get some money from the system?
Yeah, that's a great question, Ellen. So, all right, so hotspotting is a term that was first coined by Atul Gawande, and he writes for the New Yorker magazine. So if you kind of Google Atul Gawande hotspotting, you can pull out the article. And in that article, they talked about $1 Million Maury, right? And so $1 Million Maury was somebody that was in the healthcare in Camden, which literally cost $1 million, right? So this was a guy that would show up to the ER, and the nurses in the ER would say, "Maury, how are you?" And like every 3 or 4 days he would come, right? And so when we think about that, it's this concept of mapping where all the people who are the frequent flyers, the people who use a ton of healthcare utilization, how do we target them and therefore do interventions. And so this is where it was done in, Dr. Jeffrey Brenner is the leader of the Camden Coalition that was featured in that article, has bent the cost curve enormously around this. In Massachusetts, Dr. Jesse Gaeta did Home and Healthy for Good, which is very similar, where we showed that if you reduce, even with paying someone's rent and a full-time case manager and other things, you still saved $8,000 per person, because they weren't showing up to the ER every 3 days. And so when we think about that, I think there are ways to do it, but it's actually more on the insurer end than it is on the healthcare end. So when we think about, and this is where it's interesting. I was actually having dinner with a friend of mine last night who works here, and he was saying that managed care hasn't really come through Colorado that much. We in Massachusetts haven't had as much accountable care, but we're farther ahead in laying out kind of the Affordable Care Act. And so this idea of accountable care organizations is really starting to form. And so when we think about that, that is where we're talking about global budgets, right? You have X amount of money, how do you spend it? How do you see that return on investment? And so that I think that it's actually more about the insurers than the healthcare side, because though the healthcare side is interested in their outcomes, they haven't gotten the penalties yet, and it's really only penalties on the Medicare side, not on the Medicaid side. And so then you're talking 65 and up. But I do think that when we think about your natural partners in your community, it's important to map them, right? It's important to figure out, is it the insurance industry? Is it the healthcare teams? Is it your local public health agencies? Is it your local education? Is it your local chamber of commerce? Like, the levers of change, I think, may be different, but this is where the beauty of housing as a vaccine comes from, is that you have multiple benefits that you can work with to try and make that work. Well, thank you very much. You were a wonderful audience.